Welcome to Health Signals Episode 1, the podcast where insiders in healthcare help you understand whether or not what you see in the news is a signal or a trend in healthcare and beyond. I'm joined today by co-host Katherine Smart, past president of the Canadian Medical Association, one of 2022's Canada's 100 most powerful women, and an all-around amazing person. I'm Alika Lafontaine, another past president of the CMA, and 2023's Maclean's top healthcare innovator. How you doing today, Katherine?
I'm great, Alika, after your introduction. Thank you.
Oh, yeah. You know what? I could have gone on way longer. You have achieved so much over your career. I think you're just one of the most fantastic people.
Well, coming from you, I'll take that as a compliment. The feeling is very mutual. So I'm excited to be here today and start unpacking Canadian healthcare. What do people need to know?
I know. So, since it's episode 1, maybe we could just start off the docket. And there's a couple news stories that I think folks are going to be really interested in unpacking. But when we were first start talking about setting up this podcast, maybe you could share a little bit of what that process was about. Like, why do you think signals and trends are important to talk about in healthcare? What are you having conversations about with your own friends and family?
Yeah, absolutely. Well, I think, both you and I have had that opportunity to be on the front end of conversations about healthcare. We both had chances to talk to leaders in the field, both in healthcare and in politics. We've both been in the media, we've both been exposed to lots of different ideas across the country. And of course, through that, we've talked a lot with each other about what do we think. And I think as an offshoot of that, we've talked with colleagues, friends, and families. And I think what's really clear is we're at this sort of crux right now. I think this critical inflection point in healthcare where things have been getting worse for a long time, and people are really wondering what does this all mean? What's actually happening? And I think we thought this was an opportunity for us to kind of dive into those stories with what we know from our experience, both as frontline providers, because we're both still practicing physicians, and from our experiences as leaders in the field. What do we actually think about all these stories, and what's kind of the story behind the story, so to speak? And I think that's what we're hoping to do together is really dig down into what do we know? How do we see these things from those different lenses that we have from our experience? What about you? Why were you interested in this, Alika?
Well, one of them was just hanging out with you more, to tell you the truth. I think the CMA here, there's a few things that I got out of it, which I don't think I would have got out otherwise. One of them was becoming really good friends with you. So for listeners, Katherine was the president of the CMA when I was president-elect. And when I became president, she became past president. And so, we would talk all the time about different issues. And I remember many times sitting there thinking to myself, geez, if we could just record this and share this with people, they'd probably learn something about what's going on. And I just really value how your perspective, it differs from mine enough that I almost always learn something new whenever I talk about something with you.
Yeah. I say the exact same thing about you. And when people always ask me about our friendship, I always say that same thing. Certainly for me, one of the key highlights of my experience was getting to know you better, because we'd met before. Of course, we knew each other before we both embarked down the CMA journey, but we became good friends and really got to know each other, I think, as part of that. And I feel the same way. I think we both think quite differently. And I always love your approach and sort of getting inside your head and the way you perceive things. And I've learned a lot from that as well. So I think it's always great to be able to look at complex issues with someone you trust, but whose perspective isn't exactly the same as yours. It's really eye-opening. So hopefully we can sort of bring some of that enlightenment, or at least perspective, to the people that choose to listen.
Yeah, absolutely. And one of the things that's been on my own mind over the past little bit is just a lack of trusted voices. We all know people who talk about things in this space, but I don't know if you're like me. We've never talked about this before, but when you think about a health influencer in the US, for example, for me, there's a few names that kind of pop up in my head. When you think about health influencers in Canada, though, there's people that you see on CBC News and people who publish different articles, but do you think there's enough people in healthcare who are actually providing direct care, who are kind of out there asking these questions and having these conversations?
Yeah, I think it's a great point. I mean, I think during the pandemic, we saw a lot of physicians. I mean, obviously, we're both physicians, so that's more
Mhm.
our space of expertise, although we've had that chance to work with lots of different healthcare professionals. But for the point of this conversation, let's maybe talk about doctors since that's our space.
Yeah.
I think we saw a lot of people sort of step up and become trusted voices, particularly around the pandemic. However, since then, I think that's been harder. I think a lot of those conversations were really kind of COVID specific. They then extended a little bit to the healthcare system. But I agree. I think right now it would be hard if you went to your average Canadian and said, hey, name 3 healthcare professionals in Canada whose voice you hear and who you really trust when it comes to dissecting these issues. I think it would be hard. And I think the reality is, everyone's coming at these problems from their own point of view. And it can be challenging sometimes to really get at what's actually going on, and whose interests are being represented when we're talking about things, right? And I think that's part of the challenge as well. So I agree with you. I think this is an important space.
Yeah, and I think whose interest that's such a great way of framing stuff, because in healthcare, I think sometimes as physicians we try and remove ourselves from the equation, make it seem like somehow we're not making a living out of providing care, or that our lives have to be maintained at the same time as us trying to save the life across from us. Maybe you can delve a little bit into just what your current practice looks like, and what type of patient care you're providing. I'll share a bit about myself first. So I'm an anesthesiologist by training. If you don't know what that is, you're not alone. It's because the drugs work extremely well at taking away your memory. But I'm that person during surgery who puts you to sleep and make sure that you wake up. I'm the person that you call when, you're delivering a baby and you need pain relief. I help with sedation and, other type of resuscitative care around the hospital. I've worked in Northern Alberta for the past 12 years. So I think I look at myself as a rural specialist. It's a town of 70,000. We see folks from all over the place, including patients that sometimes get transferred from your neck of the woods, Katherine. So maybe you could share a little bit about what you do.
Yeah, for sure. So I'm a pediatrician. So I'm a physician for kids, everything from premature babies up to teenagers. So I look after newborns to 18-year-olds. My current practice is in Whitehorse, Yukon, where I've been for the last 8 years building a child health program. Before that, I was a pediatric emergency medicine physician at the Alberta Children's Hospital in Calgary. So I've been sort of lucky to straddle both the sort of tertiary, highly specialized end of medicine, which is, I think, often what we hear about and the voices we hear a lot in the media and in the news. And like you, I'm now a rural specialist. I love my work in Whitehorse. It's been really fantastic. We've been able to build out, I think, a really comprehensive program for children and youth in the territory. And we're coming up to our 1-year anniversary of opening our new purpose-built physical space for children and youth called Links Health, where we it's really exciting. We have a whole new space we've developed, and in there we have our pediatrics practice. We have a child and adolescent psychiatrist, 2 incredible office assistants, and a social worker who works as a patient navigator. So in that space, we provide care to all the children and youth in the territory. We also do outreach. So we visit all the rural communities in the Yukon as well. And we do a lot in the community as well, the Child Development Center, different health centers and schools. So it's a pretty, I think, cool way to practice medicine. We also obviously work at the hospital, provide acute care, medivacs. So it's really full scale. So, if people said to me, how would you summarize what you do in sort of a phrase? I would say psychiatrist by day, intensivist by night, because our outpatient practice is largely mental health and developmental pediatrics, but on call, there's of course lots of sick children. And when you're in a really remote place like the Yukon, you're kind of the person when those things happen. So it's a really wide breadth of practice. It's really exciting, and Yukoners are amazing people, and I feel very privileged to work there.
Yeah. I think anesthesia rural specialist, it's 90% kind of stable practice and then 10% pure care. When people walk in and they need care right now, you're it. You can't call for help. There's no one on the other side of the line. So.
No, absolutely. But, I want to capture something you said before, and I think this would be a great place to kind of ground this conversation. And you were talking about, obviously we're doctors, we have, this is our job. So I think, one of the neat things about medicine is, it's such a gift to get to care for people, which is incredible. But of course, like every other healthcare professional, it's also how we make our living. It's our profession, and that part's important too. And I think this idea of self-interest and sort of this kind of I guess what you might say, tension that people perceive between, altruism, which I think is a part of our profession and part of being a healthcare professional for sure, and self-interest. That tension that lies there is often at the crux of a lot of things, and I read something this morning that was saying that part of the healthcare crisis was these private agencies that have pulled people like nurses, lab techs, et cetera, out of healthcare and into this private industry because they want flexible work arrangements, sort of like blaming it on these private agencies. And I think that right there gets at the crux of it, right? We have to appreciate that altruism only goes so far. This is also people's jobs, and it's actually okay to have some self-interest. And I think when we try to remove that from the equation, like it's bad to ever be self-interested, I think we don't get at honest conversations. We have to look at what do people want and need to be able to be satisfied and fulfilled in their role. Why have people gone to some of these private agencies? Exactly that. They want flexible work environments. So when I read that, I think, is the blame on the private agency, or is the blame on the public healthcare system that hasn't listened to the people within it and actually become responsive to what their needs are? And I think that tension, and acknowledging that some self-interest is okay. Everybody has that. That's what drives the human species. It's balanced in our world because a lot of what we do in our work is, of course, trying to care for other people, and that's super important to all of us. But those two things aren't totally mutually exclusive. And I think a lot of the problems in healthcare come from people not wanting to really address that fact and almost make people feel shameful about it, right? That if you care about your own well-being, if you care about your own security, that something's wrong with you. I think that's just being a person. And I think our systems need to be responsive to that. So as providers, we can both care and be altruistic about our patients, but also feel looked after ourselves. And I think that gap between those two things is where a lot of that burnout is coming from right now in healthcare.
Yeah, and I think you're 100% right. There's an economic saying that money travels to where it's treated best. People are exactly the same way.
Totally.
Like why would you stay in a place where day after day you feel mistreated, you bring up issues, nobody wants to listen, and when you go to do the important parts of your job, you're told that you're not there for the right reasons. I've been thinking lots about this, and I'll just put my cards on the table. I'm treated extremely well as an anesthesiologist. The reason why I've stayed here for 12 years is because we have an amazing department. I really enjoy working with the people that I work with, and even if higher up I feel like we're not really heard, at the level that I work day to day, I do feel heard. I do feel like I'm a part of something. I'm a part of building something, right? And I think that that's not something a lot of folks can actually connect with right now, especially people who are off on their own. One of the things that I found compelling about the whole journey that you had to create the clinic that you were just talking about was that you had to create it. It didn't exist in the healthcare system. I don't think people sometimes realize that these places that they go where they feel really wrapped up in this like blanket of warmth, they feel like they're getting really, really good care. A lot of times it's done in spite of the systemic barriers. It's because people like you create these opportunities to find a place and create a place where people can really be seen as people.
Yeah, well, I mean, that's certainly the goal, but I think it links back to what you said, right? Like when I went about this process of thinking, okay, I'm going to move to the Yukon, I'm going to build up this child and youth healthcare program. I had already been in practice for a lot of years. So I knew this truth, right? I knew that good patient care follows happy providers. And if you are feeling fulfilled yourself, if you have some work-life integration that's reasonable, if you're feeling, paid at a reasonable rate, and you're surrounded by people who share your purpose and passion in a setup that allows you to do what you want to do, that's going to retain people, that's going to allow people to be their best, right? So I wasn't naive enough to think, it can only be about the patient care. It has to also be about how do we create an environment where providers and the physicians and all the other people that work with us feel good. So, I kind of went about it from that perspective. So when I thought about how we design our workflows, how we work together, the models we're paid in, where we're working, all those things, it was really for me always that lens of what's good for the provider is good for the patient and vice versa. What's good for our patients is good for us as the provider. So I think when you can find that balance and build that culture, then you create both excellent patient care, which I'm very confident we deliver on, but also a group of people who feel really connected to their purpose and passion in medicine. And that's where those two things intersect. But it was purpose built, and I think we often say that, function follows design or design follows function, like whichever way it goes. Yeah. But if you're not clear about what you're trying to achieve, and I think so often in healthcare, because we sort of separate those things, or we don't acknowledge enough that we have to really create an environment where providers are flourishing in order to get the patient care we want, because that's kind of not always connected in people's minds. I think we go sideways a lot. And that's why, for me, that was such a great opportunity, is it was really creating something from scratch. So it allowed us to really think about all those things and how they intersect. And I think our success has been because we've valued both things and we haven't seen them as exclusive of each other. And I think that's where we need to be much more mindful in healthcare. And I think partly because healthcare providers are sort of socialized to be altruistic and sort of sacrifice their happiness on the altar of being a doctor or a nurse or some other healthcare provider, we've often inadvertently, I don't think people have maybe meant to do it, but we've created these unsustainable work environments for people. And ultimately that impacts the patient who's at the end of that. So I think you and I are lucky that we both work with people and in spaces where we are happy with our jobs, but many people aren't. And I think it's often because those things haven't been considered in the way their work is set up.
Mm-hmm. Yeah. So that provides a good segue into our first article that we're going to talk about. This was published in the Globe and Mail on April 18th, 2024, had a ton of play across social media. Lots of folks were talking about this. It was written by Robin Urbach, titled "The Failure of Canada's Healthcare System is a Disgrace and a Deadly One." And I got to say, this is like a very well thought out takedown of the healthcare system as it's designed right now. Robin makes some really solid observations, and I think it resonated with a lot of readers. This is why it got so much play on social media. What in the article really stood out to you?
Well, I think it's, just how pragmatically she's kind of calling out the failures, right? And the word disgrace, I think, is the right one. We spend a massive amount of our tax dollars on our healthcare system. I'm saying system in quotes because, as you and I both know, it's actually not a system. It's not integrated. It's not interoperable. It's not even really purpose-built in a lot of places. It's just kind of developed over years, but not necessarily intentionally. And I think we're seeing how that lack of foresight, lack of planning, lack of listening to what people are trying to say, lack of, really thinking about the design is impacting us now with a system that's not purpose-built for what it's trying to do. And I think it is a disgrace because it's so important, right? We have to have a high-functioning healthcare system. I think Canadians expect that, and they should. It's a this whole idea of universal healthcare, it's a promise that's been made to citizens from government. But what we're not seeing really is the courage or commitment to actually fix what's broken. And I think Robin really highlighted those issues and really kind of called it what it is, right? And I think, to me, I think that's been so much of why we're not moving anywhere, is especially at the political level. We just don't hear our politicians taking accountability and admitting, like, yeah, this is actually a big broken problem, and we've got to get deep into the roots to solve it, right? What we're hearing all the time is these little solutions here and there, right? Let's pop a little money over here, let's do a little project over there to sort of try to put lipstick on a pig, right? Let's smooth it over. Yeah. But we're not actually having the hard conversations about what we're actually trying to do and how different the landscape of health and healthcare is now compared to when the Canadian Health Act came into place and when even, the idea of Medicare first started in Canada. So I think we've got to get a lot more serious about those conversations if we want to see things change. And I think articles like Robin are really a call to say, hey, Canadians, you shouldn't be satisfied with this. And I think that's the other part of the problem is a culture. We're so passive about showing our disdain for things. And I think Canadians are taking this lying down way too much. People should be out on the streets protesting about the state of affairs. It's that bad. And I think we need to be honest about it, right? And I think this desire to always sort of, it's fine. It's actually not fine. It's failing people left and right. Yes, that doesn't mean there's not pockets of people getting good care. It certainly doesn't mean that people in the system aren't extraordinary, because they absolutely are. We have incredibly well-trained people working really hard every day, but they are moving a boulder up a hill. right? The system is not designed to help them do what they need to do for anybody, I don't think. I think most of what happens is like the sheer will and determination of the people in the system who care deeply. So don't get me wrong about that, but we've got to fix that pieces around the people if we really want to start to have that impact. And I think she's calling on us to take those problems seriously and on politicians to like, let's have those real conversations.
Yeah, no, I totally agree. And I think sometimes we get this false dichotomy between we either keep a completely publicly funded healthcare system or we go totally private, or that somehow if people were able to pay out of pocket, all these problems would be magically fixed, And I want to get really concrete because when I read through this, I thought to myself, my family, like particularly my mom, would listen to a couple of these stories that she cited and just be like horrified that, this can happen in our healthcare system. One of the stories was that a quadriplegic man was stuck on a stretcher in a Quebec emergency room for 4 days, developed a pressure sore so severe that it exposed muscle and bone, and that he chose medical assistance in dying to alleviate his suffering. So that's kind of story number one.
Yes.
And then story number two is that an Ontario man who developed Guillain-Barré syndrome on vacation in Costa Rica was told he could not be flown home because there were no beds available there. So we're going to imagine that we're sitting across the couch from, close friends or family. They're sitting there going, what in the world is going on?
Yes.
And what would you do to solve these things? I'll also just acknowledge that, sometimes these stories get onto the news and people think, oh man, this is because the healthcare system has deteriorated to this level. These stories are out there. These stories have been out there for decades. They just haven't been out there in a way that's made their way back to Canadians. So It's not that these things don't happen. It's just that they're happening so much that people are now hearing about them.
Yeah.
So with story number one, I mean, we both dealt with patients with quadriplegia, depending on the type of injury to the spinal cord, sometimes you can have a little bit sensation, no sensation, but for the most part, like true quadriplegia is you have no sensation and no ability to kind of move yourself. A pressure sore is a sore that happens because of constant pressure, just like it sounds like, in the area. And when everything's functioning properly with your nerves, I mean, your body says, hey, you got to move. It's like when you fall asleep on your arm goes numb, it wakes you up. It's your body telling you this is not something that's good, right? And so, when we're treating things like this at the hospital I work at, it's really important to get people moving, rotating from side to side, transferring side to side. That's not something that's done by physicians traditionally. That's something that's done by care aides or nurses who drop by. So when I kind of read this, I think to myself, how understaffed are they when it comes to nurses in this emergency room? Where are the clinic aides or care aides who are supposed to be helping? Did they have a schedule of how to follow this stuff? I mean, sometimes people are left on stretchers and no one's really checking vitals. No one's really checking on them from time to time. What are some things that come to your mind?
Well, and also, why was this man left on a stretcher for 4 days, right? I mean, no one should be on a stretcher. Like, stretchers are for emergency things while you're moving people to a bed, right? They're hard, just for people to understand, they're a hard surface. So they would be really bad for your body, even if you were totally able-bodied, let alone someone who's paralyzed, has no sensation. They need their special purpose-built mattresses for that allow, the pressure to be distributed differently. So, how did that happen? So I agree. What we have here is, in my view, like a complete systems failure. And I agree with you. I think the lens often becomes, well, what was wrong with those people that weren't doing their job? It's like, whoa. Mm-hmm. Like, how many people were actually working? What were they being pulled to? What was diverting them away from being able to care for this person? Why wasn't the equipment there? And more importantly, why wasn't the system in place so that when someone like that comes in, clearly known to have this pre-existing, very serious, complicated medical problem, that there's not a care plan of exactly what that person needs and what delivering care to them looks like? But obviously none of those things existed, right? So this poor gentleman is parked somewhere in an overwhelmed department, and, because his problem is subacute, I guess you could say, probably a lot of people were coming in the whole time that he was there whose priorities needed that care more than he did in that moment. But then the impact over the days he sat there was that waiting, that lack of care resulted in his death. So let's call it what it is, right? He was killed by waiting in an underserviced, understaffed department that didn't have a care plan for his needs, where his needs were not met because there was not adequate people and plans in place to make sure that he got his healthcare needs addressed in our country. And like you said, this, be one thing if this was like a shocking one-off experience. This is not. There's hundreds of people dying every day in this country in similar circumstances because they're showing up in places that are not able to appropriately deal with them and care for them. Then you also put yourself in the position of imagine being the healthcare providers that were in that environment, knowing you're not getting to people, right? Knowing you're not. I remember when I was in Emerge Doc, sometimes, in certain times a year where we really have surge and you'd look and there's 80 kids in the waiting room. And all I'm thinking to myself is which one of those kids out there has septic shock or something that we haven't picked up yet. And they're literally deteriorating in this sea of people. Our nurses are doing their best. They're walking around the waiting room. They're trying to check on people. But like, what's getting missed, right? And you're just overwhelmed by this sense of angst as you're trying to care for the people in front of you of what are we not getting to? And this man was that person that no one got to. And this is happening way too often. And I think what's changing right now, because I agree with you, these aren't entirely new problems, but I think the scale of them is growing. I think the overwhelm in our emergency departments is getting more, and just the number of people, right? And some recent studies have shown just the number of people seeking care that, our population has gotten much older. People are surviving with much more complex medical problems. And these folks are showing up more and more in emergency departments looking for care. So just like the patient population has shifted, but our system hasn't shifted to meet those needs. So now it's like we're just on overwhelm constantly, right? Like, when's the last time your hospital was under capacity? We've just normalized sitting at 98, 99, 100% bed capacity all the time. So we've just pushing people on that edge always. But the most disturbing part, I think, is we're not acknowledging that this is the outcome. People are being harmed. Like, let's call it what it is. Who's out there in politics saying that? Who's out there saying our decrepit system is killing people? No one. But that's what's actually happening. So I feel like unless we're going to name it, unless we're going to be honest with the public about what's going on and start to really like get at what do we have to do. And instead, I think what we have is just people trying to divert these conversations or make these platitudes like, oh, no, our system's working really well. We apologize. This was like one thing that went wrong. Well, no, actually, that's not what it is. So let's start to be honest about it. The system's not working. That's clear.
Yeah, 100%. And I have not heard any politicians talking about how we don't have enough people to provide the care that people expect. That's actually what people need to hear.
Absolutely.
I still remember during COVID, Vernon Yu, I don't know if you were working in Emerge at the time in Alberta, but I remember Vernon Yu, who was the CEO of Alberta Health Services, came out and just talked very honestly about what healthcare providers were going through. And I personally think that was a turning point for how people in the system felt like they were being heard. Because it's the first time I had ever heard anyone, physician or otherwise, actually talk about just how horrible we were doing. How there weren't actually enough people to provide the overwhelming amount of care that we needed in hospitals and other places. I mean, it's so quick how the conversation flips back to efficiency and cutting and all these other things. Like we literally have to, in places like this, increase the number of care aides. We need to increase the number of nurses. We have to increase the number of doctors in emergency rooms. And that's a separate issue from can we find those people, right?
Yes.
So just put that on the table. But like you're hearing politicians constantly say you can get the care that you expect with less spending. That is impossible.
Agreed. And I mean, the reality is, the care has only gotten more expensive because medical technology has increased. People are surviving things that they would not have survived even within my career of 20 years. We've got children surviving the conditions that were not survivable, let alone, elderly folks. So that's exactly it. Like the cost is not coming down. It's going up. And that maybe needs to be a conversation too. Like what do we mean when we're talking about publicly funded healthcare? What should be in the basket? What's reasonable to expect? That's a whole other conversation. But I certainly agree with you. There's in no planet are things going to get better with less. Like that's not where we are. But I agree. I think that's often what we're hearing. And I think, again, what we're really rarely or almost never hearing is anyone in these leadership positions just acknowledging how bad it is. And I appreciate that's probably not politically expedient. But I also feel like a true leader names the problem and is honest with their people that are following them. And I think that's what we're lacking right now, right? I think courageously, if you want to be a courageous leader, you have to be able to be honest. And then I think you get people wanting to come with solutions, right? When people feel like they're being gaslit about the problem, they're not really wanting to be at the table coming up with solutions, right? Because then, of course, we pull back into our self-interest because that's the only way you can protect yourself. That's not what we need right now. We need everyone sort of wanting to lean in and problem solve together. But to do that, you have to feel respected. You have to feel heard. You have to feel like what you're going to say is going to be taken seriously. And I think most healthcare professionals right now would say, well, I mostly feel like I'm experiencing gaslighting. Well, that's not an environment where you're going to create cohesion to solve wicked problems. It's the opposite. And I think that's part of where we're really failing, both healthcare professionals, but also the public, is where's the courage to actually name the problem and call people to the table, but mean it, not just with the platitudes.
So let's jump to the second story, the one about the Ontario man who can get transferred home because there were no beds. Maybe you can explain to listeners a little bit what Guillain-Barré is and some of the realities around bed issues in hospital.
Yeah, for sure. So Guillain-Barré is a neurological condition where your nervous system stops working and you develop sort of an ascending paralysis and loss of motor function, and ultimately can also affect your breathing depending on sort of the height that the disease goes to. So it can be anything from someone who's, able to talk and breathe, but isn't really able to move their body, up to someone who's needing respiratory support or to be on a ventilator to support their breathing if those nerves are involved. So it's quite a serious condition. It generally improves over time, but it can be weeks or months until that happens. So there's a lot of care that's needed to support people through that illness. So, if someone like that who's trying to be transferred back, obviously they need to be transferred back to a facility and a hospital ward that's able to meet those demands. And again, the fact that our answer to someone who's developed this problem, which again, you would have no idea was going to happen to you. It could happen to any of us any day. It's not predictable. You're in another country, this awful disease occurs, and now you can't come home because there's no space in the inn. I mean, it's incredible when you think about it.
God.
Right?
Yeah.
Like imagine if that was you or your loved one. Like, what? I'm just supposed to indefinitely stay in Costa Rica with my very serious medical problem? It's unbelievable. But again, it's what we were talking about before. It's because the system is literally over capacity all the time. And it's much easier to say no to the people who are not in front of you than the people who are. Right. So when those calls come, can you take this patient? And, we experience this too, right? Trying to transfer patients, trying to move people to a higher level of care, even within the country. This is one of the biggest challenges, right? Is finding a bed. Where can that person go? Where is there space for them? And so often the answer is there is nowhere for them to go. I even experienced this in pediatrics. It's not just happening to older folks. So again, I think it just really speaks to a system that's deteriorated to the point that it is unable to meet the care demands on a day-to-day basis. And the outcome is things like this, where people are just being told, sorry, there's nothing for you.
I remember lots of situations over my 12-year career where I was providing more care than the team could provide. Two emergencies evolving at the same time.
Yes.
You only have one team working at 3 a.m. There is nobody who can run in quickly. But you just do what you have to do, right?
Absolutely.
You make do with what you have because no one's coming to help. No one's on the other side of the phone. And I think that worked for a while, but with where we're at right now, with just demand really spiking, people are sicker, I think, post-pandemic than they were before. There's a ton more people in the country, than there were before. And they deserve the same sort of care and expectations that, Canadians who have been here for a longer period of time. I think we're also realizing just how little care people in rural remote locations were getting. I'm Métis, and, we've talked about health disparities for Indigenous people for years. And I think we're just starting to see just how much those disparities actually impact care. And so you have all these things converging at the same time. Of course, demand is going to spike. Of course, systems are going to be overwhelmed. But, people talk about creating these beds without thinking about people, or they create the wrong sort of beds, or they, try and create workflows where people can't really be sent to places to get where they need and then run into worse situations. I mean, and we're trying in the healthcare system. That's one of the things that I tell family whenever they ask about stories like this. There's lots of nights where, our recovery room nurses hold a patient who's sick. I sit beside them for like hours on end because the ICU doesn't have room. And that is what we should do. That's what we should do, right? And I think people do that, but it's not a good system. It's a terrible way to solve the problem.
No, and I agree. I've had the same, for the first 2 years I was in the Yukon, I was the only pediatrician living there. So I was doing 1 and 2 call. And of course people would call me when I wasn't on call. If there was a sick child.
Maybe explain what 1 and 2 call is to the average person.
Yeah, exactly. So we talk about being on call. It in and of itself is sort of a funny term, right? So what does it mean when you're on call? On call means if there's any problem related to your area of practice, someone's going to call you to solve that problem in the time you're on call. Okay. So, in some big hospitals, really what it means is you're on a prolonged shift, right? Like if you're in a tertiary hospital on call, really what it means is you're in the building for 24 plus hours providing care. Because in those settings, it's busy enough that it would be unusual for you to actually remove yourself. Now, in a rural setting, it's a little bit different, right? The demand is slightly less, but it's unpredictable. So for me as a pediatrician, being 1 and 2 call meant 6 months of the year, 24 hours a day, people could call me at any time to come look after a sick baby or child. But of course, what would also happen is, let's say it's, a Saturday, I'm not on call, but there's a really sick baby or child out that my colleagues who are not pediatricians didn't feel comfortable managing. Of course, they're going to call me because they want to make sure that person gets care. And of course, if I'm in the territory and available, I'm going to respond, because who's going to get a call that someone needs your help and you're going to say, no, I'm not working today, right? No one really does that. You have to live with yourself. But of course, the problem with that is, I'm sure people can appreciate how sustainable is that. And then the other problem, and what happened to me a few times, is one time I was at the hospital for 72 hours. I had a critically ill patient, just what you're describing, right? Lack of resources. They needed a medevac. There was no team to come. So I was bedside, personally caring for that patient for 24 hours. Then finally the team comes. We move that patient down to Vancouver to the Children's Hospital. Great. But then something else happened. There was another one. So now I'm dealing with that, right? Then I get the call, oh, so-and-so's delivering a very premature baby. Well, at this point, I've already not slept for 2 days. But there's nobody else. That's the piece of it. There's literally, in this geographical location, no one else with your skill set. So what are you going to say? Are you going to say, well, I'm very tired, I'm not coming? No, you just keep going, right? And that's the piece of the lack of planning, the lack of sustainability. Also the risk, right? Are you at your best when I've maybe had a 1 hour nap in 2 days. Now I'm into another 18, 20 hour thing with this next really sick person. It's terrifying when those things happen. And again, we're just relying on the altruism of people to just keep going and soldiering through. And what I've really noticed now, and I think this is also what's different, is I'm seeing a lot more things happen about this place is closing, that place is closing, there's no one to do this call, this emergency department's closing. This was not happening, I don't think, before. And I think it's because people were constantly pushing themselves beyond the boundaries of these things. And again, it's not something we talk a lot about, right? Like, I'm not going to go say to the person in front of me, oh, by the way, I'm on my 60th hour of work. Like, I don't want to scare them. I want to care for them. I want them to feel confident, right? So I think these are the things we don't talk about really with patients, because we feel our job is to unload their burdens, not put burdens on them. But because of that, I think often people don't really know what's going on. And I think what's happening now is people are just over it. They're like, I'm not doing it anymore. I'm not going to work my 10th weekend in a row. I'm not going to not sleep for 4 days. I'm not, and that's why I think now we're starting to see these closures happening, which is new. And even in major hospitals, I saw an article the other day saying Surrey Memorial Hospital. This is a major, huge tertiary hospital in Surrey, British Columbia, would have hundreds of thousands of patient visits a year. They had no one on their Code Blue team for the long weekend. So Code Blue is when someone's dying, right? So this is incredible, right? Wild. This means the sickest people in the hospital, the people who are potentially dying, there's no one to come and help. This is unprecedented type of level of systems
this is like a restaurant not having someone to clean the dishes.
Yeah, this is like your house is on fire and you call the fire department and they're like, sorry, no one's putting out fires today. Like, sorry about that, it's burning down, right? Like, this is what we're talking about, and then again, they're trying, the health ministry is just like, no, everything's fine. It's like, well, is it though? Like where are these stories coming from? Why are people trying to raise the alarm? Why are our politicians then saying oh no, everything's fine. Well, it's obviously not fine. And I think, again, gaslighting people around this stuff is not helpful, right? Why is this happening? Like, we have to understand the problem to fix it, and pretending there's no problem is not the solution. But again, I just think, for our listeners, what's important to understand is, we've sort of been running on like duct tape and human sweat and like personal resilience forever to try to patch together this system. But now people are they can't do it anymore. And these are why the holes are starting to be exposed just at a level, I think, that's different. Like you said before, these things aren't entirely new, but the level of it's more, the breadth of it's more. And I think the people in the system they've just had enough. And I think, again, when they are not hearing the people in leadership positions be honest about what's going on, they start to feel like, I'm not sacrificing myself on this altar anymore. We need to fix the problem. And I think that's where we are.
Yeah. Yeah, and that takes us to kind of our second big story that we're talking about. This is also published in the Globe and Mail. Just for listeners, we do read more than just the Globe and Mail. we found these two stories pretty compelling. So it's written by Colleen Flood. She's Dean of Law, and it's titled, "At 40 Years Old, It's Time for the Canada Health Act to Have a Makeover." And I think Colleen does a really good job. She's commented as, Dean of the Faculty of Law at Queen's University on health human resources and, other types of issues in the healthcare system. She's well known to lots of folks who kind of read this type of stuff. But she kind of provides an argument that's talking about the modernization of the Canada Health Act and how there's changes happening that, its current structure with kind of its 5 pillars doesn't really account for and doesn't provide like the right kind of flexibility. And I think she makes a lot of good points. But one of the things, so I really enjoy looking at problems and then seeing the emotional arc that people go through as they try and solve them. And I think one of the things that people forget when the Canada Health Act was first passed, in the early 80s, was that across the country, there were these health systems, but there was no consistency. Everyone kind of did their own thing. And with doing your own thing, you ended up getting very, very different results. And so the Canada Health Act was really there to provide a sort of bottom threshold to what was going on. It was saying, this is the minimum that you have to do. This is the way that we should all kind of share when it comes to thinking about this problem. It was like a common vision. And I think one of the things that really frustrates me with the conversation about the Canada Health Act is that the real power of what that act was in the vision that went along with it. Like, for the first time, everyone across the country was like, oh, wow, we should probably start doing this stuff together. We should probably, start creating shared ways of doing things. We should start exchanging information about what works and what doesn't, and I mean, you can tweak the Canada Health Act, but I don't know if that's going to solve the problems that we actually have. Our problem is vision. No one can really explain what the healthcare system is now. And just like you were talking about, with vision comes foresight. We knew these problems were happening. In the midst of the pandemic, we knew people were going to be sicker. After waiting for years to get the things that they needed, things were going to get worse. Anyone that you talked to knew that, but there was no effort to use that foresight to plan. And I personally think that it's a vision problem, but interested in kind of your take on this article.
Yeah, I agree with you. And again, I think part of the problem with the vision is you look at, who's kind of holding the power around that. It's generally our elected officials, right, that make the decisions about where money goes, budgets, et cetera, how to resource things. And often our budgets are our priorities. So those things kind of dictate what happens in the system. And when you look at the vision and foresight for that group of people, right, it's, and again, I appreciate people that are in public service and elected officials, especially this day and age. I mean, this is not an easy job. But they're also, their biggest priority is their own survival. Again, it links back to what we were saying before, right? They want to get reelected. They need to try to make their constituents happy. That self-interest, which is, again, I get that. That's part of their job too. But when you're in these cycles, these 4-year cycles, and you're looking at a wicked problem like healthcare, which probably has a 15 to 20 to 30 year sort of arc to solve the real fundamental problems, what's your motivation to get in the ring on that when you know you're going to be hypercriticized? And we're living in a time now with social media, et cetera, where the criticism's just fast and furious, right? So you are constantly just trying to put out fires and survive, let alone create the space for the visioning and foresight that's going to need to happen to really get ahead of these things. And I think that's our biggest risk, is we just do not have an environment where people want to get in the ring on this stuff because it's so complicated. And people always say, elections are never won on healthcare, but they're lost on healthcare. So I think it's one of those things where people are just like, okay, let's just keep it at bay, right? Let's just keep it at bay. But that's not actually serving Canadians or getting at the bigger solutions. And I think that's a huge problem that we have, because I agree with you. We need to have a vision of where we're going. Even this concept of a health system, we don't have a system. We have hundreds of little systems. Some of them work better together than others. But, when you're in a major city like Vancouver or Toronto, and you can't even see the medical information of someone who was at the hospital, like across the way from you, it's 2024. This is a problem, right? We have very basic problems that are not helping us look after people properly, let alone all the big problems. So yeah, I think these are important conversations. I think why else it's important when we're talking about the Canada Health Act is also just people understanding what the healthcare system is and isn't. Canada really has a universal insurance policy that covers hospitals and doctors. That's really what universal healthcare is. So even calling it universal healthcare is a misnomer, right? What you have is, quote unquote, free or publicly paid for access to physicians for medically necessary services, and your stay in hospital is going to be covered. That's it. All these other things are not. Now, of course, sometimes they are, right? Of course, provinces and territories decide how to spend their money, and lots of other things have come into the basket. And depending where you live, those things are different, but they're not consistent. They're not necessarily sustainable, and they're changing all the time. So again, I just think, is that really the only thing that matters to get a functioning healthcare system? Is that physicians and hospitals are paid for, or is there more to it? And then I think the other piece of that we're really seeing right now, if you want to bring in the primary care piece of it, is why is primary care failing? Because, there's nothing in there about guaranteed access to a primary care provider. Who's paying for the infrastructure of primary care? I often think right now of the business model of medicine. Anyone right now who's doing anything would acknowledge that with inflation and just changes, especially post-pandemic, the cost of everything's going up, right? Rent, utilities, staff. It's like a curve like this. Physicians work in an environment where their fee schedule is flat. And most physicians that provide community-based care are paying for that infrastructure of healthcare, the buildings, the staff, all of it out of their earnings. So when you're in a model where your earnings look like this and your costs are, so your earnings are flat and your costs are escalating and the demands and needs of your patients are getting more complicated, what are you going to do? You're going to fold and walk away. And that's what's happened so much. And again, that links back to our other issue of the human health resource crisis, because there's endless demand for the human health side of things. You can go find a job doing a million different things when you have that broad skill set in the system, because there's needs everywhere. So you've just created this environment where you haven't actually created a sustainable model. And there's no accountability, right? The government doesn't guarantee you that you're going to have a primary care provider, and they're actually not accountable to you if you don't have one. So you've got this perfect storm where nothing's aligned, there's no plan, and then you wonder why it's not working. I mean, I don't think it's very surprising, but here we are, right? And I think that's what's really interesting in Jane Philpott's new book. She's really calling for a primary care act, saying that governments guarantee access to a primary care provider, just like we guarantee access for schools, right? And I love that analogy because I think that's something most Canadians can relate to, right? When you move into a neighborhood, you have a child, your expectation is they're going to go to school, somewhere around where you live, right? My expectation is not that my child in Whitehorse is going to go to school in Grand Prairie. It's that they're probably going to go to school in Whitehorse, right? But that's not, we don't have that for healthcare. So I love, and then also that idea of, we don't also expect the teachers to build the school, provide the toilet paper, provide the chalk to write on the board, right? We expect that infrastructure's there and their job is to come in and teach. Now, I appreciate that's a bit of an oversimplification because many teachers inject resources into their classroom to improve them. But what we've really done with primary care is we've created zero infrastructure. Physicians have created all of it in a small business model. Well, it's not surprising that's not responsive to the needs of the population because there's no plan, right? And it's not surprising that model starts failing when the costs of executing on those things is exponentially increasing relative to what people are able to earn in that style of medicine, and here we are. So I think those types of this is an example, right, of a clearly articulated vision. Dr. Philpott articulated a vision that people could understand, relate to, and go, oh yeah, that inherently makes sense to me. Primary care should be like a school. You should move into your zip code. There should be a place that's ready to absorb you. That place should be fully operational, funded, and accessible to me, just like a school. So I think, those are the types of conversations I think that could help Canadians start to wrap their mind around, like, what could different look like, right? Because I think that's the other challenge we have is when we're talking about change, what do we mean? And people don't always know, and that can be scary. So I think this is the type of vision we need. And what I love about it is it creates accountability, because I think that's the other major problem right now in our system is the government's not accountable to you at all to provide you with anything. And you have no recourse as a citizen if you don't get the healthcare you need. What can you do? Nothing.
Yeah.
So
and
here we are.
I think parsing that accountability is something folks don't think about too. Like you and me, we are accountable to patients. You show up,
yes,
and you're bleeding, or you have sepsis, like overwhelming infection that's causing a bunch of derangements and blood pressure and the way your organs function and stuff. We're not going to abandon you. Like we're just going to figure it out. And I think the accountability at that patient to provider interface, that's where the system has focused all of its resources.
Yes,
we have
agreed.
endless standards that talk about us not abandoning patients, rightfully so. Rightfully so. We talk lots about people reporting, being followed up for quality improvement, patient safety, all that other stuff. But like, if it is actually a system problem, no one can see 500 people on an 8-hour shift. It is impossible. But there's no accountability for the system to make any changes to make sure that you have enough people to see all the folks in need of care, but everything's just pointed at that one person who's on call to try and have them push that boulder up the hill, like you said, which is just totally impossible.
Yeah.
And so one part of this article actually stood out to me. I'll just quote it here. So the federal government, this is from Colleen Flood. So the federal government should require each province, in exchange for a federal contribution, to set down a public process for determining benchmarks for reasonable access, including metrics for timely access to primary care. So going pretty good so far. Elective procedures and emergency rooms, these benchmarks should be subject to periodic review and adjustment based on emerging evidence and best practices in healthcare delivery. Doesn't this sound like wait times?
I was going to say, I feel like we've done this before. Deja vu. Well, again, this is the problem, right? Like these things, yes, in theory, yes, this is a great idea. But if there's no stick at the end of it, right? Like if nothing happens, then it doesn't matter. And we've been down this road a million times, and then what happens, right? Certain things like in BC, right? They tied some funding to wait times for hip and knee replacement. Okay, this is important. But then all the resources go there. And then it's like, squirrel. Okay, we're over here. Let's fix that problem. But then all these other things like are getting ignored, right? So it has that unintended consequence of diverting energy and attention to one small part of the system, which is important and great for those people who benefit from that, but away from all the other problems. And I agree. Like, I think without that accountability being built in, like what actually happens, what does it really matter? And that's where I can't see the link being made is like the outcome. And again, I think this is part of the challenge of our federated model. We've got the feds kind of the ATM of healthcare, the provinces and territories happily collecting on their deposits, but with really zero accountability about what they do with that money. And a great example was we heard, post-pandemic, like in my area of practice, $3.2 billion coming from the federal government to the provinces and territories to deal with the acute crisis in pediatrics, right? We all remember the headlines last year, the disaster of the tridemic, kids just overwhelming emergency departments sick with viral illnesses on a backdrop of, counseling pediatric surgeries, wait times for imaging. Most people might be shocked to know kids actually wait longer than adults in pretty much every domain of the system, from mental health to diagnostic imaging to surgery. So there was this, a lot of advocacy, which was amazing, and the federal government committing this money. How many provinces and territories do you think have put in place a plan to make sure those dollars get to children and youth? Guess.
0.
No, 2.
2? Oh, this is better than I thought.
We're better than 0.
Yeah, this is good. This is good.
Ontario and Nova Scotia. But that's it, right? So here we are. This ages later, well more than a year later. Money's on the table and no one's made a plan. This is like, so you just go, okay, like what? Like, how is this happening? Right? Why does no one know about this? Why are people not upset? Because I don't know what's happened. Like, we're just so used to it. We just expect it. My own theory is, I think because we also fearmonger people about the American healthcare system, we're almost like quivering in the shadow of the US, just afraid that any change means the American system, which arguably is progressing faster than our system in terms of addressing equity issues, et cetera. Not perfect by any means, but they're moving. Well, we're just stuck in paralysis of fear of change, of fear of what that looks like, fear of difficult conversations, and we're getting nowhere. And again, like, this is why I just think we need to elevate the conversation, because if the response to everything is, oh, we're going to have this American healthcare, no one's saying we should have American healthcare. Why don't we look to Europe? Why don't we look to countries that are doing really well and emulate some of those things that are happening? Let's learn, right? We don't have to reinvent the wheel here, but we don't want to take the lessons. And we just keep coming back, and then we keep rehashing. It's like 90s fashion. Everything old is new again. Yeah, let's have benchmarks that mean nothing, that no one does anything about. Like, when does the rubber hit the road for patients? That's what I want to know.
Yeah. Mm-hmm. Yeah, and I think that it's the right question. And in future episodes, we can take these conversations in multiple different directions. But I think explaining to people about, what's actually happened in the past, what was in place. I constantly get frustrated with this. All these problems are new.
Yes.
We've never had to deal with this before.
Yes.
There have been plans after plans, research after research, but I think the average Canadian, and rightfully so, like, why would people think about healthcare if they're not unhealthy?
Yes.
Don't see historically all these different things that have been going on. So, we're going to take a long form approach to this podcast. We're not going to cut our conversations like some other podcasts that you might listen to. We're just going to speak about stuff. We'll likely have guests booked on in future episodes. I think that this is a good place just to wrap up this conversation. But, I sit back and I really hope listeners, after going through these discussions, walk away kind of thinking to themselves, hey, these are solvable problems, because they are. All of these problems are solvable. You might be on mute now, Katherine. We might cut that part out.
Yes, the reason I went on mute is because you may hear my dog, who's going crazy in the background, because either he really agrees with us that these are solvable problems that Canadians should care about, or someone's at the door. Either is possible, but I agree with you. I think the whole goal here is to get people engaged, thinking about this stuff. Let's elevate the conversation. We can change things, but we've got to be honest together. So I'm looking forward to how this unfolds with you.
Yeah, absolutely. All right, and that's a wrap for episode 1.